Welcome to Clinical OBG lecture series. So, in the previous video, we looked about detailed history taking. Now, let's go into clinical examination. So, consider the following relevant points during examination of any antenatal case. So, the basic gadgets required for examination of an antenatal case. So, just one is the weight and height measurement tool, and in figure B you can see the knee hammer, the inch tape, stethoscope, sphygmomanometer and thermometer. So these are the basic gadgets you'll be requiring for the examination of an antenatal case. So now diving on to the general examination. First, you need to see if whether the patient is comfortable at rest. Then look for the build, whether the patient is medium built or well built or thin built. Then look for the nourishment, whether adequately nourished or poorly nourished, height of the patient, the weight of the patient, the body mass index BMI, that is weight in kg divided by height in meter square. So pre-pregnancy body weight or weight in the early first trimester is usually taken for calculation of BMI. So you need to generally for calculation of BMI, remember guys, this is the common mistakes that students do while calculating BMI. They take the current weight. No, you need to ask for the pre-pregnancy weight must be asked to calculate BMI. Now check for any abnormal gait or any spinal deformities such as kyphoscoliosis. Check for pallor, icterus, cyanosis, clubbing, lymphadenopathy and pedal edema, which is PICL. You need to note that the presence or absence of pallor and pedal edema are the two general examination findings that are usually noted during each antenatal visit. So generally, from general examination, pallor and pedal edema are the common ones that you'll be finding during examination. Coming to the vitals. So first look at the temperature, whether afebrile or febrile. If febrile, mention the temperature in degrees Celsius or Fahrenheit. Then pulse rate, and describe the rhythm, the volume, the character, and whether all the peripheral pulses are equally felt. Example, pulse rate is say 84 minutes, regular in rhythm, normal volume and character, and all peripheral pulses are equally felt. Coming to the respiratory rate and blood pressure, you need to say that the blood pressure is dash mmHg, measured in right upper limb in sitting or left lateral position. Now moving on to the thyroid examination. Mention whether normal or presence of any thyroid swelling, that is the thyroid moves with deglutition. Next, coming on to breast examination. Mention whether the breasts are normal or whether there is presence of any retracted nipple or fissures or discharge from the nipple or any palpable mass. Now let's move on to the systemic examination. So in systemic examination, that is cardiovascular system, if it is normal, mention as clinically normal, S1 and S2 heart, no murmurs or within normal limits. Serious abnormalities are mentioned in part 1. Okay, and so we'll be detailed cardiovascular system examination, we'll be dealing it in detail in the chapter 5, that is cardiac disease in pregnancy. Now respiratory system, if it is normal, you just mention it is clinically normal, that is normal vesicular breath sounds are heard within normal limits. and if any abnormal findings are detected like creps, ronchi, diminished breath sounds, etc. Now coming to the obstetric abdominal examination, this is very important, guys. So the prerequisites for obstetric examination include the following. Explain the procedure to the patient. Then obtain her consent. Ask the patient to empty her bladder. Ensure privacy. Get a screen prior to examination. This step usually students forget. So you need to, before even starting your abdominal examination, just after getting consent, you need to ask the patient to empty her bladder so that it will be much easier. Then you need to ensure the privacy, ensure there is adequate lighting, stand on the right side of the patient. A male doctor should have the presence of a female attendant during examination. Ask the patient to lie down in supine position and cover the lower limbs with a blanket. Request the patient to undress the parts to be examined. Warm your fingers and examine from non-tender to tender area. So first, moving on to inspection. Abdominal distension and contour. Look for the abdominal distension and contour and note whether flanks are full or not. So what do you mean by flanks? Flanks means the region below the rib cage and above the ileum. And then look for the umbilicus, whether normal, everted or flushed with skin surface. Then look for the linea nigra and stria gravidarum. So in this figure you can see the linea nigra. So this blackish line is your linea nigra, and here there are certain stretch marks, and this is stria gravidarum. Note for any scars or sinuses. Cuff impulse at hernia orifices is checked. Mentioned as cuff impulse is present or absent at hernia orifices. So if any scar is present, check for cuff impulse at scar sites. Why do you do this? In order to rule out incisional hernia, you need to check for cuff impulse at scar sites. Now next, moving on to palpation. First you will be looking for the fundal height. So how do you look for fundal height? First you need to position the patient. So the patient should be in dorsal position. So this is the position of the patient, dorsal position, with legs flexed and slightly abducted. So this is the position of examination. So in dorsal position with legs flexed and slightly abducted. Correct the dextro rotation of the uterus with the right hand. So with the right hand you can correct the dextro rotation of the uterus. Now, so in this figure A, you can see the position of the patient in of obstetric palpation. In the figure B, there is the demonstration of the fundal height. Now, you need to palpate with the ulnar border of the left hand. Ulnar border of the left hand to determine the upper border of the uterus, either from below upwards till disappearance of resistance of uterus, or from above downwards till the fundus of the uterus is felt. So that is appearance of resistance. So basically guys, so you take your ulnar border. So with the ulnar border of your left hand, you start feeling for resistance, and this resistance denotes the uterine fundus. So with your ulnar border of your left hand, you will be determining the upper border of the uterus. Usually it's done from above downwards till the fundus of uterus is felt. Before taking away the palpating hand, ask the permission of the patient and mark the fundal height of the abdomen. So this is how you mark the fundal height of the abdomen. So before even taking away the palpating hand, ask the permission of the patient and then mark the fundal height of the abdomen. Now next, moving on to symphysiofundal height. So what is symphysiofundal height? First, positioning the patient. The patient should be in dorsal position with legs extended. So the legs must be extended for measuring the symphysiofundal height. Measure with a measuring tape with the inches side facing up. Okay, and place one end of measuring tape over the pubic symphysis and take the tape across the umbilicus up to the marking of the fundal height of the abdomen. So you need to take the tape, guys, and from the pubic symphysis across the umbilicus you need to mark, okay, the fundal height of on the abdomen. Okay, so now you need to turn the tape to check for the symphysiofundal height measurement in centimeters. Now you need to turn and measure it in centimeters. Now symphysiofundal height measurement is the only examination done with legs of the patient in extended position. This is very important point to remember. Usually for fundal height, what will we do? For just looking at the fundal height, you'll ask the patient's legs to be flexed and abducted. Whereas in symphysiofundal height, the legs of the patient must be extended. So with extended legs, the reference point of the pubic symphysis remains the same at each visit, while symphysis may move up or down with different degrees of flexion of the thighs. So in this figure, this is the pubic symphysis, guys, and this is the top of the uterus. So the landmarks for measuring symphysiofundal height is pubic symphysis and the top of the uterus. Whereas for this is how the symphysiofundal height is measured, from the pubic symphysis till the top of the uterus. It's measured. Now coming to Leopold's maneuver, very important. The name is important, guys. In Viva they will ask what is the name of the obstetric what is the maneuver in which obstetric grips are done. It is known as Leopold's maneuver. Leopold's maneuver. So Leopold's maneuver gives the obstetric grips. So the aim is obstetric grips help in determining the fetal lie and presentation. Okay, so why do we do obstetric grips? It is mainly to determine the fetal lie and presentation. So grips are performed usually after 34 weeks of gestation. Very important. So if there is a antenatal women with just 28 weeks of gestation, you are not even going to look for the grips because it cannot be palpated properly at all. So very important question is, when will you perform grips? Grips are performed only during more than 35 weeks of gestation. Very important. Only after 34 weeks of gestation grips are performed, as the fetal lie and presentation remain viable prior to this period. So demonstration of the obstetric grips. So this is how they are. The first one is the fundal grip. The first one is the fundal grip. They are palpating the fundus. In the second figure, you can see the lateral grip. So lateral grip, and next lateral grip, both the sides will be seeing. Knob-like structures denote limb, and a smooth uniform structure denotes spine. And next is the first pelvic grip, and then this is how you do the second pelvic grip. First pelvic grip and second pelvic grip. So let's talk about each of them in detail. Obstetric grips. are done with the patient in first dorsal position with legs flexed and slightly abducted, the same position, because it relaxes the abdominal muscles, which makes palpation much easier. Obstetric grips must be performed in a relaxed uterus. So palpate gently with ventral aspect of the fingers of one hand. The examiner faces towards the head end of the patient for the first 3 maneuvers and faces towards her foot for the 4th maneuver. Okay. So for the last pelvic grip alone, the examiner will be facing towards the feet of the patient, whereas the rest of them, the examiner will be facing the face of the patient. Now first grip. So the first grip is the fundal grip. So fundal grip is the first Leopold maneuver. Okay. So fundal grip, how do you check for fundal grip? Palpation is done facing the head end of the patient. Now you need to palpate the fundus of the uterus with both the hands. So you need to palpate the fundus of uterus with both the hands. So this is the demonstration of fundal grip. Now if a smooth, hard, globular, smooth, hard, globular, each word is important, guys, very very important. Smooth, hard, globular, palatable mass is felt, then it is suggestive of fetal head. So fetal head, what are the characteristics? Smooth, hard, palatable, globular mass is suggestive of fetal head. Now if a broad, soft, irregular, non-palatable mass is felt, it is suggestive of breech. So all the 4 words for each of them is very very important, guys. For fetal head, what are they? Smooth, hard, globular and palatable. If in case of breech, what is it? Broad, soft, irregular, non-palatable mass. Now next, moving on to the lateral grip or the umbilical grip. This is the second Leopold. So second Leopold is the lateral or the umbilical grip. Palpation is done facing the head end of the patient. Steady one side of the uterus with the palm of one hand while palpating the other side, and then do vice versa. Okay, so first use the palm of one hand and while palpating on the other side, and then you need to alter. So palpate one side first and then the other side. So the inference, if it is a smooth, curved, uniform, resistance felt. If there is a smooth, curved, uniform resistance felt, it is suggestive of fetal back or fetal spine. If small, knobby, irregular parts are felt, it is suggestive of fetal limb birth. So these 4 characteristics are very very important. I am revising once again, guys. Fetal head, smooth, hard, globular and palatable. Breech, broad, soft, irregular, non-palatable. Now moving on to second Leopold, that is lateral or umbilical grip. So if it is smooth, curved, uniform resistance, then fetal back. Small, knobby, irregular parts, then is suggestive of fetal limb births. Now next, moving on to the pelvic grip. So we finished fundal grip, the first Leopold, lateral or umbilical grip, which is the second Leopold. Moving on to the third Leopold, that is the first pelvic grip, also known as Paulick's grip. Very very important. First pelvic grip, also known as what, guys? Paulick's grip. Okay, so first pelvic grip, otherwise known as Paulick grip. So Paulick grip, first palpation is done facing the head end of the patient. Now using the ulnar border of your right hand is placed over the upper border of the pubic symphysis. So you place your take your ulnar border of your right hand and place it over the upper border of the pubic symphysis. Now, palpate the fetus between the outstretched thumb. You need to palpate the fetus between the outstretched thumb and the four fingers of the right hand. Okay. So, using the ulnar border of your right hand over the upper border of the pubic symphysis, you need to palpate the fetus between the outstretched thumb and the four fingers of the right hand. Now, what is your inference? So, if you look at the figure A, so the left hand is used for stabilizing one side of the abdomen, and palpation of the other side of the abdomen is done with the right hand. So this is the demonstration of lateral grip. If you look at the figure B, the right hand is used for stabilizing the abdomen and palpation of the opposite is done. So this is the demonstration of lateral grip. Now, demonstration of first pelvic grip. So using the ulnar border of your right hand with thumbs and the rest of the fingers in between, you are going to palpate. Okay, so what will be your inference? So the first pelvic grip is mainly done to identify the presentation of the fetus. So you need to know what is the presenting part of the fetus. So suppose, say if it is a smooth, hard, globular, ballotable mass, then it is suggestive of fetal head. If it is broad, soft, irregular, non-ballotable mass is felt, it is suggestive of breech. So whether the presenting part is engaged or not, how will you check if the presenting part is engaged or not? So suppose if the presenting part is freely ballotable, then it is not engaged. See, if the presenting part is freely ballotable, then it is not engaged. If the presenting part is fixed or non-ballotable, then it may be engaged. So this is how you will differentiate whether it is engaged or not engaged. So in a transverse lie, the first pelvic grip is always going to be empty. Remember, if the lie is a transverse lie, then the first pelvic grip is going to be empty. Now moving on to the fourth Leopold maneuver, which is the second pelvic grip. So examination is done facing remember this alone, the last fourth Leopold alone is done by facing the foot end of the patient. So only the obstetric grip that is done facing the foot end of the patient, okay, is going to be your second pelvic grip. So this grip is usually done at term pregnancy. Okay, remember it is done at term pregnancy which has crossed 37 weeks of gestation to check if the presenting part is engaged or not. So this is the demonstration of second pelvic grip, guys. So if they are going to converge, if both the hands are going to converge, then it is not engaged, and if they are going to diverge, then it is engaged. So I'll explain you this. So first you need to place both hands on either side of the abdomen above and parallel to the inguinal ligament. This is important. So both the hands placed above and parallel to inguinal ligament. Parallel to the inguinal ligament. Now palpate simultaneously with both the hands and move medially and downwards. So what will be your inference? The second pelvic grip confirms the findings of the first pelvic grip, that is the presentation of the fetus and whether the presenting part is engaged or not. It gives additional information about the attitude of the head, encephalic presentation, whether well flexed, deflexed or extended head. So it also gives additional information about attitude of the head in cephalic presentation. So following the obstetric grips, mention regarding the following, okay? About uterine activity, about liquor content, about scar tenderness. So uterine activity, whether the uterus is relaxed or irritable or acting. About in liquor content, whether average or excessive or reduced in amount. Scar tenderness to be checked in previous cesarean pregnancy to rule out impending scar rupture. So the suprapubic region is gently palpated with the palmar aspect of the fingers of the right hand, and the patient's face is simultaneously looked at for any wincing or discomfort due to pain. So this is eliciting scar tenderness. Now next, coming to auscultation of the fetal heart rate. So how will you auscultate for the fetal heart rate? So first you need to check for fetal heart rate on the side of fetal back. Very important, on the side of fetal back along the spino-umbilical line. So if you look, if at all the spine is here, so along the spino-umbilical line you look for the fetal heart rate. So over the side of the fetal back along the spino-umbilical line you look for the fetal heart rate. So fetal heart rate is heard best with the bell of the stethoscope, okay? So you need to count for 1 minute and mention the rate and regularity. So you need to count for 1 minute and mention the rate and regularity. Like for example, the normal fetal heart rate is around 120 to 160 beats per minute. 120 to 160 beats per minute. So this is how. So along the spino-umbilical line, where the fetal head is the fetal back is going to be present, you will be auscultating for the fetal heart rate along the spino-umbilical line. That too using the bell, not diaphragm but bell of the steth. What you need to notice, fetal heart sounds are heard through the back of the fetus, that is left scapular region, in vertex and breech presentations, and through the chest of the fetus in face presentation. So if it is a face presentation, then you need to auscultate over the chest of the fetus, whereas in vertex and breech presentations, back of the fetus. So next, coming to estimated fetal weight. So how do you calculate estimated fetal weight? So estimated fetal weight is calculated using a formula known as Johnson's formula. So how do you calculate estimated fetal weight? Using a formula known as Johnson's formula. So there is a formula that is Johnson's formula. So what is this Johnson's formula? It says that the estimated fetal weight is equal to symphysiofundal height minus 11 or 12 into 155 in grams. Very important, guys. How do you estimate the fetal weight? So estimated fetal weight is given by Johnson's formula, which is nothing but symphysiofundal height minus 11 or 12 into 155 in grams. Symphysiofundal height minus 11 or 12 into 155 grams. So take the value. If you are taking the value as 11, when do you take the value to be 11 and when do you take the value to be 12? So if at all the head is going to be below the level of ischial spines, so if the head is going to be below the level of ischial spines, then you need to take the number as 11. If the head is at or above the level of ischial spines, then you need to take the value as 12. So very important formula, Johnson's formula, estimated fetal weight is nothing but simplifies your fundal height minus 11 or 12 into 155 in grams. So when do you take 11? When the fetal head is below the level of ischial spine. If the fetal head is at or above the level of ischial spines, then the value taken should be 12. Now next, moving on to the obstetric pelvic examination. So in obstetric pelvic examination, a routine vaginal examination is not required in any antenatal period, guys. So it may be indicated only in cases with any complaints of vaginal discharge and pelvic pain. So a vaginal examination may be performed at or after 38 weeks of gestation and during labor to obtain information about the cervix, the presenting part, the membranes, as well as the pelvis. So generally in any antenatal examination, you do not perform vaginal examination. There are some exceptions to it, like if the patient complains of any vaginal discharge or pelvic pain, then you rarely go for vaginal examination. Otherwise, it is done only after 38 weeks of gestation, during labor, and also any information about the cervix, the presenting part, the membranes, and the pelvis. Note: the UG medical students are expected to perform only the obstetric abdominal examination and the inspection of the external genitalia. That's all. You should only do inspection of the external genitalia and obstetric examination. Don't go for vaginal examination, guys. However, one should be able to answer viva questions regarding the pelvic examination also. Whereas PGs are expected to do obstetric pelvic examination in indicated antenatal cases. So what are the prerequisites for vaginal examination? So there are certain prerequisites for vaginal examination. So the patient is first asked to empty her bladder, explain the procedure and get an informed consent, ensure adequate privacy and lighting. The patient should be in dorsal position with thighs flexed and slightly abducted and buttocks placed at the foot end of the table. So this is the dorsal position of the patient for speculum and vaginal examination. Hands are washed with soap or antiseptic solution and sterile gloves are going to be worn before examination. The patient's vulva and perineum are swabbed with Salvin or betadine prior to the procedure. So obstetric pelvic examination procedure, first you need to go for inspection of the external genitalia. So what all will you inspect? Over the external genitalia? So inspect the mons pubis, the labia majora, the labia minora, the perineum, the anal region for any ulcers, warts, skin lesions, varicosities, and any vulvar edema. Then the labia are separated to inspect the urethra, clitoris, and introitus. Next, moving on to the speculum examination. You need to know all about speculum examination. So this is how a speculum examination is done. So this is your speculum. This is your speculum examination of the vagina. Okay, so what you can see here is your uterine cervix. So speculum examination is done prior to bimanual or vaginal examination to visualize the vagina and cervix. So with the help of a good light source, what is the speculum name? Sims speculum or Kuskow's bivalve speculum. Very, very important, guys. What is the speculum name? Sims speculum or Kuskow's bivalve speculum. These names are very, very important. Sims speculum or Kuskow's bivalve speculum. So Sims speculum or Kuskow's bivalve speculum is inserted into the vagina under aseptic precautions. So look for the following: any any abnormal discharge, leaking PV, bleeding PV. So this is the speculum examination. What is the name? Sims speculum or Kuskow's speculum. So in the figure 1, you can see the insertion of Kuskow's speculum, and then there is visualization of cervix after insertion of Kuskow's speculum, and this is your Sims speculum examination. So you look for any after bleeding PV, leaking PV, you can also look for any ulcers or lesions. Cervical smear for exfoliative cytology, that is pap smear, or any vaginal swab for culture may be taken if indicated. Now next, so this is all about your speculum examination. So next, moving on to bimanual examination. So how do you perform a bimanual examination? So this is done in early pregnancy when the uterus remains a pelvic organ itself and it is not an abdominal, organ. So it remains a pelvic organ. That is when you go for bimanual examination. So the index as well as the middle fingers of the examiner's right hand are going to be introduced into the vagina, while the left hand is going to be placed in the suprapubic region and the uterus is palpated between the abdominal hand and the hand in the vagina. Do a gentle and systemic examination and note the following. In cervix, you need to look for the consistency, position, and any cervical pathology. So in uterus, look for the size, shape, position, and consistency to corroborate the size of the uterus with the period of amenorrhea in early pregnancy. And adnexy, any mass or tenderness fell through the fornix. So this is how you perform bimanual pelvic examination. So what are you doing is with your index and middle finger of your right hand, you will be introducing it into the vagina, and whereas the left hand will be placed in the suprapubic region, and the uterus is going to be palpated between the abdominal hand and the hand in the vagina. So in between, you will be palpating the vagina. You'll be palpating for the uterus. So in cervix, what you look for is consistency, position, any cervical pathology. Uterus, look for size, shape, position, consistency, or any mass or tenderness. Now next, moving on to vaginal examination. Vaginal examination is indicated usually prior to induction of labor or during labor for following reasons. First is to do a pelvic assessment to rule out cephalopelvic disproportion. So in order to rule out cephalopelvic disproportion, you do a vaginal examination. Then to assess cervical ripening prior to induction of labor, to assess fetal presenting part and position, to do artificial rupture of membranes. So in Viva they may ask, when all do you perform vaginal examination? So these 4 points you need to say, guys. First is to rule out any cephalopelvic disproportion, then to assess cervical ripening during induction of labor, and to assess the fetal presenting part and position, and to do artificial rupture of membranes. So this is how you do vaginal examination. So first, in vaginal examination, you will be noting the color of if the membranes have ruptured, to rule out any cord prolapse following the rupture of membranes, to assess for cervical effacement and dilatation during labor, to assess the station of the presenting part, to note the progress of the labor, to confirm second stage of labor. All this must be looked for during vaginal examination. So So moving on to case summary. So how will you write the summary of history and examination? So it should include the patient's name, age, obstetric index, GPLA, LMP, EDD, POG, chief complaints, significant positive and negative history, associated complications, salient findings in general and obstetric examination. That's it. So for an example of a provisional case diagnosis, so I'll read out this example. Say a 24-year-old, okay, Mrs. Dash, of age dash, GPLA, her obstetric score is dash, at dash period of gestation, with diagnosis of say anything, GDM or hypertension. So with a singleton live fetus, in cephalic presentation, not in labor, with a singleton live fetus in cephalic presentation, not in labor. So that's how it goes on. Okay. So we have finished the examination part. So now we need to move on to the investigations and management plan for the case. So the investigations relevant to the given case that aid in diagnosis or management and a brief plan of management for the given case are to be noted. So you need to be ready with the summary of the case, as examiner may ask you to present only the summary of the case. Okay, so summary of the case is very important. Okay, this is how the summary will be given. So let's discuss certain points in history taking and clinical examination. So first, name of the patient. So name of the patient, documentation of patient's name is necessary for what all? First, identification. So the examiner, these are all your viva questions. So why are you asking for the name of the patient? This is your viva question. So what will you answer? First is for identification of the patient, then addressing the patient, and to build a rapport with the patient. Now why do you ask for husband's name? To avoid confusion among patients with the same name in ward. So usually there will be many patients with the same name in ward. In order to avoid confusion, you also ask for the husband's name. Now what is the importance of age? Very important. What is the importance of age? Obstetric complications are more common in case of teenage pregnancies and in advanced maternal age. Risks associated with teenage pregnancy, that is age less than or equal to 18 years, and advanced maternal age, that is age greater than 35 years, okay, are given here. So these are the risks associated with teenage pregnancy. So this is a viva question. So the viva question is, what are the risks associated with teenage pregnancy? So there are antenatal, you can divide them into antenatal, intrapartum and postpartum risk. So in antenatal, you can have anemia, malnutrition, abortion, preterm labor, IUGR and preeclampsia. In intrapartum, it can be either a contracted pelvis, cephalopelvic disproportion, increased rate of C-section, perineal injuries during delivery. In postpartum, any failed lactation, emotional upset, etc. So these are all the risks associated with teenage pregnancies. Now moving on to the importance of residence. So what is the place you're residing? So what's the importance of it? So you need to look for the accessibility to health services in case of obstetric emergencies. So how accessible is the health service for the patient? So that's for any kind of obstetric emergency, that's why you ask for residence. Now, we saw the risks associated with teenage pregnancies. Now, let's look the risks that are associated with advanced maternal age. So, in advanced maternal age, again the antenatal issues will be abortion, preeclampsia, chronic hypertension, GDM, over diabetes mellitus, fibroid complicating pregnancy, IUGR, fetal risk chromosomal abnormalities such as trisomies and Down syndrome. Intrapartum risks will be uterine inertia, incoordinate uterine action, operative interferences such as instrumental deliveries and C-section. Postpartum is failed lactation. So generally, if the maternal age is very advanced, failed lactation is very common. And abortion, preeclampsia, GDM, hypertension, these are all very common if there is a advanced maternal age. So how do you plan admissions? So to plan admissions, a woman from a remote area may require admission at term or safe confinement. Okay, may require admission at term or safe confinement, while a woman residing close to the hospital may be asked to come for admission with onset of labor pain. So with onset of labor pain, the admission can be there. So a patient residing close to the hospital may be managed on outpatient department. Okay, so if suppose the patient is residing close to the hospital, may be managed on any OPD basis in cases of mild preeclampsia and GDM, etc. So some areas endemic for certain diseases are going to be filariasis, leprosy and iodine deficiency. So that's how you plan admissions. So what is the importance of education? So why do you ask for the education of the mother, or the education of the woman? So educated women are in a better position to understand the importance of antenatal care and follow-up. Compliance may be more in educated women regarding diet advice and drug intake. So compliance is more. And to decide on management plan for cases with GDM, preeclampsia, etc., whether to treat on OPD basis or as an inpatient. Educated women are more compliant for follow-up and can be managed on OPD basis very easily. So that's why education is important. Now next, what is the importance of occupation? So women may be prone to any occupational hazards such as take radiology department, there is exposure to radiation. Any IT sector, stress is a very common factor. Agricultural workers, hookworm infestation is very common. In case of construction workers, abortion due to lifting heavy weights. Oh my god, so just see, due to lifting heavy weights, abortion may occur. So that's why construction worker history, occupation history is very important. So next, moving on to the importance of socio-economic status. So the complications associated with the lower and higher economic status are given here. So complications associated with the lower socio-economic status are anemia, malnutrition. These two are very important complications. Rheumatic heart disease, tuberculosis, sexually transmitted disease and hookworm infestation. Whereas the complications associated with higher socio-economic status is the sedentary lifestyle, obesity, post-dated pregnancy, pregnancy-induced hypertension, GDM. All of this, sedentary lifestyle, post-dated pregnancy, pregnancy-induced hypertension and GDM. These are all complications associated with higher socioeconomic status. So based on the socioeconomic status, you should give a proper advice on diet. So suppose in anemia patients, The patients can be advised to take meat, liver, egg yolk, etc. So if they can afford these, while those not able to afford such foods can be advised on cheaper alternatives, rich in iron, like greeny leaf vegetables, jaggery and ragi. So prescription of drugs. Cheaper brand of drugs may be prescribed for patients who cannot afford, but to buy costly medications. So socioeconomic status is one of the important determinants of health status. There is no direct measure of the social status of an individual. Several methods or scales have been proposed for classifying population by the socioeconomic status. So let's look at the common scales. So you have the Kupusami scale used in urban areas, modified B.G. Prasad scale used in both urban and rural areas, Uday Parikh scale for rural areas. Okay, urban Kupusami, rural Uday Parikh scale, but modified B.G. Prasad scale is used for both urban as well as rural areas. So Kupusami socioeconomic status scale. The modified Kupusami scale is based on composite score considering the education and occupation of the head of the family and also the monthly income of the family that yields a score between 3 to 29. So this is the Kupusami scale based on education of the head of the family, occupation of the head of the family, monthly income of the head of the family. Now coming to modified B.G. Prasad scale, this is what they'll mainly ask you guys. So modified B.G. Prasad scale is based on what? Per capita monthly income. Very, very important question. So modified B.G. Prasad scale is based on per capita monthly income. So roughly you have, there is class 1, 2, 3, 4 and 5. So class 1 is upper class. That is more than per capita monthly income more than around roughly 6,300. And class 2 is upper middle class. That is roughly between 3,000s and 6,000s. And class 3 is middle class. That is roughly between around 2,000s. And class 4 is lower middle class, roughly between 940 to in the range of thousands. Okay, and class 5 is lower class, that is less than 938. Okay, so the importance of nearest health center is very, very important. Okay, so what is the importance of nearest health center? First is accessibility. Any accessibility to health services in case of emergencies. To decide on management, whether to treat on OPD basis or inpatient. So accessibility to health services in case of any emergency, and to also decide on management whether to treat on any OPD basis or as inpatient. Now next, coming to the importance of period of gestation and expected date of delivery. So what is the importance of POG and EDD? It helps in many aspects of diagnosis and decision making in pregnancy. Complications in primary gravida. So complications in primary gravida is increased risk of preeclampsia, preterm labor, cephalopelvic disproportion. So now what are the complications? So these are the major 3 complications in primary gravida: preeclampsia, preterm labor and cephalopelvic disproportion. So complications in grand multi gravida are, so again, antenatal period anemia, malpresentations due to pendulous abdomen, multiple pregnancy, placenta previa, in intrapartum incoordinate uterine action, rupture of uterus and postpartum hemorrhage, in postnatal subinvolution and a failed lactation. So these are all most complications in multigravida. So now let's look at the importance of various history that is taken in first trimester. So what are the, okay, so I think the examination part, the basic viva questions, what are the importance of asking name, all of these are covered in this video. So in the next video we will be covering on the relevance of history of the present pregnancy, okay, in first trimester in all example with detailed questions, viva questions, okay. So to continue this lecture series and to cover up to learn more, yeah, do subscribe this channel and like and share so that you know are engaged and you get more videos to watch. Thank you.